Welcome everyone to this special CTSNet webinar, International Perspectives on the AHA, ACC, SCAI Coronary Revascularization Guideline. Thank you for joining us. Please note this webinar is being recorded and will be available Tuesday morning on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce Marjan Jahangiri, Professor of Cardiac Surgery at St. George's Healthcare NHS Trust, who will moderate this session. Welcome, Marjan, and I'll turn it over to you.
Ladies and gentlemen, colleagues, on behalf of my panelist colleagues, we would very much like to welcome you to the discussion of 2021 ACC-AHA guidelines for coronary artery revascularization, which was published in December 2021. I would like to introduce to you my colleagues, Dr. Hirokuni Arai, who's professor and chairman of the Department of Cardiovascular Surgery at Tokyo Medical University. He's representing the Japanese Association for Coronary Artery Surgery. Dr. Victor Dayan, cardiac surgeon and professor of cardiac surgery at the National Institute in Montevideo, Uruguay. He's representing the Latin American Association for Cardiac and Endovascular Surgery. Dr. Chris Malaisrie, Professor of Surgery at Northwestern University, representing the AATS, American Association of Thoracic Surgery. Dr. Patrick Myers, Consultant Cardiac Surgeon in Geneva, who is Secretary General-elect of EACTS, representing the European Association for Cardiothoracic Surgery. Last but not least, Dr. Joseph Sabik, Chairman of the Department and Professor of Surgery at Western Reserve University, representing the Society of Thoracic Surgeons. Colleagues, as you can see, we have an international panel which is essentially encompassing nearly all the continents in our universe. This shows you how important we feel that these guidelines are. These latest ACC-AHA guidelines are meant to replace the previous 6 most recent guidelines. It has attracted wide interest and controversies. It is not endorsed by any surgical societies to the best of my knowledge. Some of these areas of controversies that we will address today include downgrading of CABG from class 1 to 2B in patients with triple vessel coronary artery disease. Downgrading of proximal LAD lesions with normal left ventricular function from 1 to 2B. Awarding class 1 recommendation to radial artery as a CABG conduit. Importantly, the guideline committee has equated PCI with CABG under the wide umbrella and title of revascularization. They have become synonymous. Any cardiologist or cardiac surgeon who practices these specialties recognizes there are vast differences in the performance, mechanism, and outcome of these 2 very different procedures. Also, the key members of the guideline committee, it was a vast committee, but there were only 8 surgeons out of 24. These guidelines have really relied on one of the more recent trials, which is called ischemia trial. It is not our remit to discuss the ischemia trial with you in detail. However, I would just like to go through some of the points of the ischemia trial because the guideline committee looked at it as new evidence. Ischemia trial was not powered for death or myocardial infarction. It didn't compare revascularization to medical therapy. Revascularization, they said, the ischemia trial author said revascularization was only performed when feasible. I'm not quite sure what that means. They had a median follow-up of 3.2 years. However, we all know that the benefits of CABG become evident more than 5 years follow-up. Despite the fact that it's recommending or making recommendations on triple vessel coronary artery disease and proximal LAD lesions, only less than 40% of the patients had these lesions. Again, similarly, 40% were not actually randomized. Going back to CABG was performed in less than a quarter of the patients, knowing that half of this population in the trial had diabetes. So I think it is fair to conclude that the impact of CABG in this trial was very much underestimated. These are just some of the points I wanted to mention to you about the ischemia trial, because the trial that we are about to discuss with you relied on it heavily. But in addition, the current guidelines and its panel has overlooked the vast body of evidence, labeling it as old evidence, which had demonstrated superiority of CABG over PCI on long-term benefits, including repeat intervention and post-procedure myocardial infarction. So essentially, a lot of our trials that we have relied upon for many years, in my eyes, for no obvious good reason, they have been omitted. Now, I'd like to open our discussion to our illustrious panel and just see what they think of the ACC AHA trials, in what way their practices have been affected locally and nationally in their regions, and any other points that they would like to share with us. If I may please, I start with Dr. Arai. Very welcome. And Dr. Arai, just tell us what's going on in Japan and in your practice, please. I apologize, Hirokuni, you're muted.
I'm sorry. I'm sorry. Thank you very much. It's my great honor and privilege to be invited in such a worldwide exciting movement. Yeah, actually, what's happening in Japan is so far it looks like guideline impacted not so much. Probably Japanese guideline did not revise at this moment, but we cardiac surgeons have serious concerns in the future. So because in patients with stable angina pectoris, there is a probability of a shift in thinking and paradigm from early coronary angiography to coronary revascularization is unnecessary and may even be harmful to the patient. And so this guideline lacking most important effects of CABG, which is CABG is a prophylactic treatment leading to survival benefits, and this benefit increases gradually over years. So the recommendation of optimal medical treatment as initial treatment instead of revascularization may cause delay of proper treatment of the patient. This would obviously harm the patient. And moreover, in real world, I think not all the patients can continue optimal medical treatment. But as my personal experience, many patients of my outpatient clinic who are treated by CABG doesn't suffer angina, even if they discontinued optimal medical treatment. So our opinion is, instead of first optimal medical treatment and then CABG and PCI, we strengthen the first optimal medical treatment over CABG and then consider PCI. It's my opinion. Thank you.
Dr. Arai, thank you very much. Would you just add, just tell us, do you have a reimbursement system in Japan, or does in any way these guidelines may affect that?
Yeah, in Japan, the problem is the unbalanced PCI and the CABG is a big problem in Japan because all of the Japanese people are covered by government insurance. And most of the PCI, how much stent it is, usually the stenting is covered. So right now the ratio is 19:1. The PCI to CABG is 19:1. I think it's the overuse of PCI. It's a big problem. But then maybe this guideline might have impact on the overuse of the PCI. So because they further shift to the optimal medical treatment, but I don't think anything changes for the reimbursement for the CABG by this guideline.
Thank you very much, Dr. Arai. I'm sure we'll come back to you for some more isolated questions. I can see Dr. Victor Dayan's hand up. And also, Victor, I'd be grateful if you can make some comments on this trial and give us the, obviously, the Uruguay perspective and also the perspective of the Latin American Society. We have read your very thorough statement, which is an open letter in the internet. And thank you for sharing that with the worldwide public.
Thank you, Marjan. Thank you for your great introduction regarding the previous data on which the current guidelines have supported the recommendations. It is an honor for me to be sharing with you this session with this prestigious panelist and with all of those who have put some time in order to connect themselves. I would just like to add, Marjan, something very important that you said regarding the references to which the current guideline authors have supported in order to support this downgrade of recommendation, which was mainly the ischemia trial. And let's don't forget ourselves that stable ischemic heart disease is the most frequent presentation of patients with coronary artery disease, and the most common anatomic presentations are patients with multivessel disease. Therefore, chapter 7.1 of the current guidelines has the impact of affecting millions of people in the world, millions of people. And therefore, if we are going to change a recommendation in a guideline, it has to be based on a very extensive external validated trial, which ischemia is not. If we see of over 20,000 patients that were considered to be enrolled in the ischemia trial, 68% of those patients were not enrolled, which shows that the external validity of the ischemia trial should not be used in order to affect the potential of millions of people worldwide. So now regarding our local reality, our regional reality, our reimbursement is based mainly on governmental recommendations, and our governmental recommendations are generally based on ACC, AHA, or European guidelines, and mainly class 1 recommendations. But as a matter of fact, our governmental recommendations have not changed after these ACC, AHA, SCAI guidelines, which poses some kind of credibility from our government and from the people who assess the government in scientific issues regarding the new recommendations of these guidelines. So this is the situation, not only Uruguay, but also other South American countries also based the reimbursement on recommendation, on a normative, which is based on North American and European recommendations, which have not modified themselves according to current recommendations. And as a matter of fact, and this is just a personal anecdote, being a surgeon, I am one of the most fervent supporters of the ischemia trial, and in some way, some of the recommendations of the current guidelines when we do our rounds in our university. Interventional cardiologists and cardiologists are one of the most opponent to the current recommendations of the ACC, AHA, and the ischemia trial, which is some kind of a controversy, right? So that's my opinion.
Victor, thank you very much for these pertinent comments. And I'd like to emphasize to our audience what you said. This is not a niche condition affecting, I don't know, 1,500 people worldwide. We're not treating a fancy condition. It's the thousands and millions of patients will be affected by this treatment, their symptomatic and their prognostic status. So thank you very much for bringing that comment to our attention. If I may please, our next panelist is Chris Malaisrie. Chris, thank you very much for being with us. Just tell us what's going on in the States. You've got a very big country, and just tell us, at least in and around your region.
Well, thank you, Dr. Jahangiri, and thanks for CTNet for inviting me to this panel. I am representing AATS, however, credit must be given to Dr. Sabik, who led the rebuttal, which was published by both the Annals and JTCVS, and I'm representing it not as an expert content. Dr. Faisal and Len Girardi are expert contents on this, but I am an end user, just like everybody else. And one theme that I think highlights the controversy of this guidelines is the continued undervaluation of coronary bypass grafting. And the impact that I have is as an end user, like everyone else who's listening on this webinar. In particular, what we do for patients who have coronary artery disease and are asymptomatic or mildly symptomatic. And we recently looked at the SDS database, and a quick review showed that the class 2B recommendation for multivessel disease and normal EF affects up to 40% of the patients that the average cardiac surgeon sees in the United States. And as an end user, the frank discussion I have with my patients is a very important one. Now, fortunately, many patients aren't experts on reading guidelines, but some of them are. I see doctors who need coronary bypass grafting or asymptomatic, and it does frame this discussion differently when there's a class 2B recommendation for survival, as opposed to class 1 recommendation previously by the Americans, and still a class 1 recommendations for the Europeans.
I'm sure you'll agree that, as you said, it's very difficult for patients to navigate their way through guidelines. I find it difficult to navigate my way through guidelines, let alone patients who, some may be literature savvy, some may be in biomedical sciences, but nevertheless it's very difficult. So I think it's our duty to make sure every guideline is consistent and is as accurate as possible. Chris, just tell us a little bit, is there an issue with reimbursement which may relate to these guidelines?
No, fortunately, no, but that is a very interesting subject for all the societies, whether or not these will affect clinical practice guidelines. And I am very concerned. These guidelines, which we all take a part of, are meant to be guidelines that we can trust, and it is used to shape practice and inform our practitioners as to how to treat our patients. So I think there's going to be more to come on that, Dr. Jahangiri.
Chris, thank you very much. Our next panelist is Dr. Patrick Myers from Geneva. As I said, he's our Secretary General-elect of a European Association and is representing the European Association of Cardiothoracic Surgery. Patrick, you've had a major role putting us all together. Thank you very much. And I hope we continue with a lively discussion. Tell us what you think in the beautiful Switzerland and on behalf of EACTS.
Well, thank you very much, Marjan, and a pleasure to join this esteemed group. Now, obviously, these guidelines are for North America predominantly, but they do apply worldwide. I mean, these are a synthesis, a summary of the best evidence by content experts. So they're going to have an effect worldwide. And all these patients, we discuss them in our heart teams. And so this is already going into our heart team discussions, even if we have our own European guidelines. They date back to 2018. We're currently revising our left main chapter. And so having more up-to-date evidence coming, even if it's from a different region in the world, they do have an impact also in Europe. Now, in terms of reimbursement, we have so many different public health systems in Europe that I can't speak for most of them, but definitely there are some that where having a 2B recommendation for CABG will likely have an effect on reimbursement. Here in Switzerland, for the moment, that's not the case, but it may be the case in the future.
Patrick, thank you very much. When might you envisage that we have the, if you like, left mainstem guidelines revised from EACTS and European Society of Cardiology? I know you've all been working hard, but it can kind of link to this. And I'd like to ask you and Dr. Sabik something a bit later.
Well, we're actively working on that. There's a task force working between ESC and EACTS on this subject. The ESC Clinical Practice Guideline Chair, Colin Bagent, disclosed to TCTMD a few months ago that this was going on. I don't have any date for publication, and agreements haven't been reached quite yet. So we're still working on it, but hopefully we'll hear about this soon.
That's great. Dr. Joseph Sabik, we're very honored that you've taken time out to be with us. We're delighted. Please tell us a lot about this trial. Take us through some of the basics. Give us your criticisms and your praises, if there are any. But please inform us as much as you can.
Well, thank you very much, Marjan, and it's a real honor for me to be, part of this symposium today. A lot of esteemed colleagues on the symposium. This has kind of been, very difficult, I think, and it's been a very arduous process. And, it's really a shame because, in the end, who suffers from something like this is our patients. And we really want what's best for our patients. I think as you've said, Marjan, as well as our panelists, the thing that we have the hardest recommendation to deal with is the fact that they downgraded coronary artery bypass surgery in patients with 3-vessel disease from a level of recommendation 1 to 2B in light of no new evidence suggesting that should happen. I mean, you'll occasionally see a single level downgrade, but this was a 2-level downgrade, which was really surprising. I think the other important thing for all of us to remember is that the only coronary revascularization procedure that's been demonstrated to prolong survival is coronary artery bypass surgery. As you are all familiar with, the Joseph meta-analysis of several randomized trials, demonstrated in patients with left main disease, triple vessel disease, patients with 1 or 2 vessel disease that involved the LAD, they had a survival benefit from coronary artery bypass surgery. Now, obviously PCI can help in symptomatic improvement, but there's never been a trial that demonstrates PCI prolonged survival. Whether we look at Courage, VERY2D, FAME2, or Orbita, which was a PCI versus a sham trial, had not demonstrated any prolonged survival. But despite that, these guidelines have both PCI and CABG as 2B recommendations. So it's hard for us, our societies, to understand how when we have one procedure which has been demonstrated to have a survival benefit, and an important one, that is now equal to a procedure that has never been shown to have a survival benefit. I think the other important things to consider is that we have excellent trials, and I'll use syntax. If we look out at 10 years, we have a 40% improvement in survival in patients who underwent bypass surgery versus PCI. And the only way that we can say that CABG doesn't improve over optimal medical therapy is that if PCI hurt patients. And we know from these trials of PCI versus optical medical therapy, it doesn't hurt patients. It just doesn't improve survival. So again, there's a loss of logic there. And we can also look at things such as Excel, which showed, again, a survival benefit in patients having surgery versus PCI. So the evidence is overwhelming, but for some reason that was ignored. I think the one thing that makes me nervous is it starts with guidelines, and then we enter into what's called appropriateness criteria. And you can imagine a 2B recommendation suggests that the risk it doesn't outweigh the benefit. So all of a sudden now it's probably, you could imagine that we could say that it's appropriate to treat patients with triple vessel disease with ischemia. And so well documented by Dr. Malaisrie on how important that is in treating patients, that it may be appropriate to first treat them with medicine. But we know from the use of meta-analysis that that's going to result in death in patients. It's not the right way to go. And then appropriate criteria then takes reimbursement. And so I think what we're very fearful of is that, yes, these are just guidelines now, but eventually they could affect, practice and reimbursement. I think other important things to state is that there are cardiologists who are surprised, and very prominent cardiologists, and even cardiologists who have been authors on the ischemia trial, don't believe these guidelines and this downgrading is correct. What I have noticed is, experienced cardiologists are surprised, but those that don't have the experience to have seen the benefit of coronary surgery in their patients are going to be influenced by these guidelines. And I personally had the experience in talking to cardiology fellows. They're learning, they're new, they're going to go, oh, we don't need to refer triple vessel disease to surgery anymore. We can treat them medically. That scares me and keeps me up at night because that's going to harm patients.
Thank you
Dr.
very much.
Jahangiri, I'd like to pick up on what Dr. Sabik eloquently expressed. And the one point that also came out in the combined document from STS and AATS is the undervaluation of the benefit of CABG. So when we write guidelines, we balance benefit versus risk. And optimal medical therapy has gotten better over the past several years, and that was cited by the writing guideline committee as a reason for downgrading, double downgrading of CABG, because medical therapy has gotten so much better. But medical therapy also makes CABG look better as well. And another thing that people have to understand is those older trials that were summarized by USEF meta-analysis, at that time, operative mortality for CABG was 3%, 30-day operative mortality. And all of us should be congratulated for the good work that we do in coronary bypass grafting. The safety that we provide our patients is remarkable. And that was highlighted in the recent FAME-3 trial, where 30-day operative mortality after CABG was only 0.3%, which was identical to the 30-day mortality after PCI. That's a 10x reduction in risk for CABG for our patients with multi-vessel disease.
Thank you very much for your excellent comments. And I have received some chat questions. I'm going to refer to them later. Colleagues who are on the screen, I'm not ignoring you. Dr. Sabik and yourself, you've referred to the prognostic benefit of CABG. The same that it seems that has been overlooked by the current panel of ACC and AHA. So the prognostic benefit has been put aside. Let's say as a junior resident, registrar, whatever it's called locally in your countries, I was always told CABG is performed for two reasons. One, symptomatic reasons. Two, prognostic reasons. And then we came up with various risk stratifications. So put this aside, I don't know, for 25 years, I have learned to explain the prognostic and symptomatic reasons. And I remember many years ago, we often heard of the chap in his 50s and 60s dropped dead in the street. We hear it a lot less. So put the prognostic benefit, the sudden cardiac death aside. Then the same guideline discuss patient choice. Patient choice, a well-informed patient choice. One of you referred to our patients being well-read and learning from the guidelines. But where is our duty? What I mean is that how can I go to my patient, give my opinion, your opinion that I've heard now, which is completely against the current guidelines. The patients can only be guided by us, and the patient choice is there. But ultimately, the patient wants to know what is the best practice from us as, if you like, as specialists. So I have a problem. I think the guideline has a dichotomy about this patient choice. And increasingly so, many guidelines write about patient choice as if it's, forgive me, suddenly is the new nucleus of atom discovered. We've always listened to our patients. We've always wanted the best. I'm sure I'm speaking on behalf of millions of clinicians in any field. So I think there's a dichotomy with them emphasizing patient choice, but not giving the entire evidence. So in fact, we're influencing the patient choice in an uninformed way. This was just a personal comment of mine. We have received, obviously, some controversies that you've discussed. May I please ask Dr. Meyer and Dr. Sabik, you have significant say in our current guidelines and future guidelines, either in progress or future. How do you think we should go forward from here? Patrick, do you want to start?
Sure. Well, I think a good start here is seeing that we have representatives of societies around the world that are coming together and discussing these main issues. I think that we need to have our surgical voice heard worldwide. And I think that working together, we do become much stronger. Now, we do need a process for independent review of the evidence. We're all surgeons. We all have intellectual conflicts of interests. We don't have any nefarious intentions, but we believe that what we do, CABG, BIMA, radial, whatever technique it is, we're doing that in the best interest of our patients because we believe in that. There's nothing nefarious in that. But this goes back to when we have our guideline discussions with our colleagues from cardiology, we're looking at exactly the same evidence, but seeing it in a vastly different way, just because we all have our own intellectual conflicts of interests. We need to be able to remove these conflicts of interest. And I'm just talking about the intellectual side. One suggestion is to have an independent group that use some frameworks, such as the GRADE framework, to have an independent and reproducible method of summarizing the evidence, and then submit these recommendation tables to a writing committee constituted then by content experts who could then elaborate on these recommendations. I think that there are already out there many different recommendations for how to write guidelines. The Institute of Medicine's Guidelines We Can Trust, the NICE UK methodology. Now, what we saw in these guidelines, one really important issue is that they used unpublished subgroup analyses from the ischemia trial to decide on their recommendations. Now, the NICE UK recommendation states clearly that any data that needs to be discussed by their panel has to be submitted in advance. And the goal for that is that one content expert who has access to unpublished data will not be able to sway the panel by saying, oh, well, in this trial, we saw that this. No, the data has to be out there. Everybody has to be able to take a look at it and see it independently. Here, if we just look at the recommendation, the downgrade for CABG, essentially we're saying that the ischemia trial enrolled more CABG patients than many of the other trials that Joe was mentioning previously. And so just on the number of patients, the duration of follow-up, we have more data than all the previously published trials. The issue is, as you stated, Marjan, very well, the choice between PCI or CABG was not randomized. This was based on regular practice, meaning that the patients with more complex disease included in the trial were likely undergoing CABG within the invasive group. On the other hand, in the conservative group, well, we don't have any data on the anatomy. So how can we even be comparing CABG to any control group? So really, I'm sure that the ischemia group is working on publishing a comparison of CABG versus the other groups, but this is non-randomized data. So how is this going to inform our recommendations? And this just illustrates, yet again, how data that wasn't publicly available, and that may not be the best data out there, swayed tremendously these recommendations. We need to be able to put in processes to standardize how we develop these guidelines so that we can do this in a reproducible manner. I just wonder if we bring together a different panel looking at exactly the same evidence as was used for these ACC, AHA, SCAI guidelines, if we would reach the same conclusions. I don't think so. And I think that our guidelines are not reproducible at this point. Hopefully we can improve that, but still quite a bit of work to do there.
Before I go to Dr. Sabik, and I know Dr. Dayan had his hand up, for our audience, what Dr. Myers is referring to, of course, is explained, but the part of these guidelines are based on the unpublished subgroup analysis of CABG. They're unpublished. Obviously, if they're unpublished, they're not peer reviewed. So I think, Patrick, am I right? That is one of your objections. That's
Absolutely.
great. Thank you very much. Really pertinent comments. Dr. Sabik, tell us, how are we going to repair this? It's one thing complaining about it and having our discussions, one thing putting it right. It's always difficult to put things right.
Well, thank you. Obviously, Dr. Myers' comments are right on. And what I would say is, I think the first step is the unity. I personally have never been involved or have seen, cardiothoracic surgeons come together like they've come together to make sure the right thing is done with patients with coronary artery disease. I think that's the first step, because we need to be heard. And the amazing support across the world, I think, is step one. And then, as you said, now I think we need some calm people, to take a step back and say, how do we improve this process? Because it's not in anyone's best interests for the cardiologists and the surgeons not to agree. We need to work together to come up with the best guidelines to treat our patients. I personally have a few ideas on just some tactical ways we can all move forward together. I think the first thing is we need equal number of surgeons and cardiologists. I think that's just fair. And I think the surgeons should be chosen by the surgical societies, and the cardiologists should be chosen by the cardiology societies. Both groups can weigh in on how they believe these people will work together. But in the end, each society has to pick their own representatives, because there's wisdom in the society. And I believe those surgeons need to work with their societies in representing them at these guideline tables. I think, as Dr. Myers has pointed out, we need more than just content experts. We need people at the table who understand how to interpret studies so that we don't over or under interpret the value of a study. I think as we pointed out so well today, the ischemia trial was not designed to compare medical therapy with revascularization. It was designed to compare a conservative strategy versus an invasive strategy. And when you get into the details, you see a lot of crossover. Over 20% of the patients in the invasive strategy never underwent angiography. Of those that did undergo angiography and revascularization, 72% had multivessel disease, with, I believe, about 30% having two vessel disease. And less than 20 or 21% of the patients had coronary surgery. More patients in the conservative therapy had angiography than patients who had coronary surgery in the invasive strategy. I don't mean to degrade a study. Doing any randomized study is hard and difficult, and you always have to applaud the researchers. But we can't over-interpret and over-apply. And I think that was one of the things, that we've learned. I think also not just having a majority vote, but following some of the Institute of Medicine's guidelines, maybe 75% of the writing committee needs to approve a guideline or a downgrade. And then also, I think there should be an opportunity for public comment. These guidelines should not be published without the world having the opportunity to review them and weigh in. You know, they come out and it's almost, you know, like an announcement, as opposed to why doesn't everyone have the opportunity? Because it affects everyone's patients. So I think there's a lot of things that we can do to improve the guideline writing process. And to me, again, I think it's so pointed out when EX talked about these guidelines, is we want it to be a heart team approach. Can we really have guidelines when there's only cardiologists on that heart team?
They're excellent comments. I just interject with a question and a comment. You've mentioned representation from both cardiologists and cardiac surgeons from their respective societies. You have referred to the international voice of all of the clinicians involved in the care of these patients. As a practicing doctor, I either look up to the American guidelines or the European guidelines. Because, as Patrick Dayan said, this involves so many patients worldwide. Can you and Patrick Myers think of an international guideline? Have representatives from everywhere. I'm just thinking with you. So if you are considering it, if you think we can do something and modify it, please consider involving more than just the NICE, the AHA, and the European. Because I've read very well informed and well studied critiques and praises of these recent guidelines. It's just something if you would consider. Patrick Myers, sorry, Victor, you've been waiting for a bit. Patrick, your hand is up.
Yes, I just wanted to come back on one of the comments that Joe made, which I think was outstanding, is opening up the guideline for public comment before it is actually published. Having been privileged to work on the valvular heart disease guidelines, which were published last year in Europe, it's true that we're so much in our silo of working, of negotiating recommendations that we can believe in, that once we have the finished product, we're very, within these guideline committees, we're very removed from daily reality of surgical practice. And I know that in terms of our VHD guidelines, I was quite surprised by some of the uproar that came out of it. I know some of the surgeons on this ACC AHA guideline on coronary revascularization very well, and they were very surprised by the uproar on some of the subjects. So I would just like to underscore how important that opening up for public review, I think, is.
Thank you very much, Patrick. Victor, you've had your hand up and it went down. Please tell us. I'm sure you had an interesting comment.
Yes, thank you, Marjan. And I think the issue with the current guideline is a little bit more worrisome than only the issue around coronary artery revascularization. I think the issue is we are having a dangerous step forward in performing or giving non-evidence-based recommendations. So this is quite a very dangerous step that the current ACC, AHA, and SCAI guidelines have performed. Downgrading recommendation from class 1 to 2B without any type of evidence from CABG versus optimal medical treatment is a very dangerous step forward. I think we are not realizing that important problem and dangerous consequences that this could have in future guidelines. Because if we are not doing an internal review of what is going on here, therefore we're giving openness and we are allowing for future guidelines to make recommendations without any evidence based. So this is a very important issue, and I think it goes hand in hand with Dr. Sabik said regarding the openness and the possibility of having a public review like NICE does of their guidelines before their official publication. because once it is published, you get responses just from the ACC leadership, in which these guidelines are like the tables of Moses. They're not possible to modify any single comma. And when you read the text of those guidelines, it's totally controversial. Not controversial, but contradictory. You get in the text something that goes totally in the other direction than what is in the recommendation. So you don't know what to read. You have to read the table or you have to read the text. I think this issue is extremely important, and it's very important that all societies have spoken the word in order for future guidelines to make themselves more carefully. And regarding the people who should make these guidelines, I have the problem that professional bias is very difficult to extract from the guideline authors. And I personally think that PIs or people who are involved in these trials should not be part of the guidelines, because even though they have not received any financial compensation, the trials are their son, their daughter. They're going to defend himself and those trials to the end of the world. They are not going to allow for criticism in these guideline committees against those trials. So I think, as Patrick mentions, it has to be an independent group of authors, which ideally should be mainly cardiologists with experience in methodology, in which a new review is performed on these trials. And we do not rely only on the 4 or 5 reviewers who have reviewed for New York, for JAMA, for other authors, before approving that manuscript. I think a new extensive review of those trials should be made, and before allowing itself to be labeled as class A, level A of evidence or not.
Patrick, there was really excellent comments. You've highlighted some of the inherent deficiencies of writing guidelines and reporting them. And you have diverted us from what we're always obsessed with, if you like, conflict of interest, which naturally one thing's financial. But as you said, it's not financial. In fact, the stakes are very low. The lower the stakes, the more important the actual topic is. Colleagues, thank you very much. If I may, I'm going to open our panelists to some questions and some comments. The first comment is very interesting, from Dr. Claudio Pariola from Italy. She's asked, he's asking, why not anybody from AHA or ACC is with us today? Claudio, I don't know. Can anybody answer, Claudio?
I would say that we're a surgical association, and so we wanted to discuss this among surgeons. But of course, we're always open to talk with our colleagues from cardiology, and the heart team approach, I think, as we've said repeatedly, is very important, and glad to have some on board.
Demonstrating the international interest of, I hope, this gathering, Dr. Vikram Kumar from Karachi in Pakistan. He's asking, how do you people are facing cardiologists after the ischemia trial, especially about stable ischemic heart disease? I think we hope they haven't read it.
Maybe I can just pose a comment. Our cardiologists are the ones who are unwilling to accept the results of the ischemia trial. As I mentioned earlier, I am one of the most fervent supporters of evidence-based, but we have our cardiologists who do not want to accept those results. They really do not want to accept it.
That's great, colleagues. Another comment from Dr. Habib Taref. He's asking, does this downgrading in the guidelines involve impaired left ventricle function or only normal left ventricular function? Any of you would like to answer?
So it does not involve patients with impaired function that got a very high level of recommendation from the guideline committee, recommending the importance of the most recent trial that showed the 10-year result benefit of surgery in patients with impaired ventricular function.
That's great. If I may, I just add a comment for Dr. Tarif. Yes, it has been downgraded, particularly in proximal LAD with normal left ventricular function from 1 to 2B again. Thank you, colleagues. Our next comment, somebody has written a comment, but it's not appearing. Dr. Ellie Elman, she's asking, where have we seen so far the left main disease patient pool? My interventionalists have been driving patient to non-surgical options. I think probably Dr. Elman is referring to left main stem disease and equivalence of some of the trials in managing left main stem disease. Would you like to make a comment, colleagues?
Yeah, I know in these guidelines, coronary artery bypass surgery has a higher recommendation than PCI. You know, having been involved in some of these trials, I think what I would like to tell everyone is when we look at left main disease, the vast majority of patients with left main disease have triple vessel disease, about 2/3 of them. So those patients are not even getting enrolled in these studies. It's really a subset, and we look at NOBLE and EXCEL. Obviously EXCEL had some issues around the definition of perioperative myocardial infarction. But again, those definitions, this study was designed, 14 years ago. We've learned a lot since then. But when we look at NOBLE, for instance, they did not have a difference in mortality. But again, most of those patients where we would consider in those lower risk syntax complexity groups 1 and 2, but we did have an importance in decreased repeat reintervention and decreased spontaneous MI. NOBLE decided not to tackle perioperative MI, so that was not one of their endpoints. As you know, in EXCEL, there was a mortality benefit for patients undergoing surgery, as well as a decrease in spontaneous myocardial infarction and repeat reintervention. And at 5 years, those curves continue to diverge, suggesting continued benefit of surgery. The controversy in EXCEL has been really around this issue of perioperative MI and definition, which seems to suggest that at least the composite endpoint, was not different. But when you break it down into the components, very, very strongly favoring surgery, in my opinion, with mortality benefit from spontaneous MI and repeat reinterventions, and curves that continue to cross. So I think it's reflected in these present guidelines, and I bet there'll be, I'll make a guess here, that this benefit will play out also in the European guidelines when they are rewritten in left main disease, that surgery is more beneficial than PCI in patients with left main. But again, the caveat, and just to discuss, is that in all of these trials, there's always selection bias. And in randomized trials, it occurs in who is put in these trials. And I think everyone in putting patients in these trials want to have equipoise. And patients with complex disease who also have left main, which is the vast majority of patients, are not in these trials. Those patients are having surgery and benefit from surgery. It's the low complexity patients that are enrolled in these trials. And at least to my interpretation, surgery is still better.
Thank you very much for your comments and the answer to our participants. The next question, please, is from Dr. Anthony Manlulu, again on the left main stem subject. He says, revascularization is not just about symptoms. It's about the risk of subtended myocardium as well. Absolutely. Would anyone recommend medical therapy for asymptomatic left main? Excellent question.
It's a very interesting question, and I think it refers to all anatomy, right? How many of us, with patient, had triple vessel disease with severely stenotic vessels would not think that that patient benefits from surgery? When you look at the use of and the analysis, survival was not dependent on the level of symptoms. It was dependent on the anatomy at 10 years. And so the argument, I think, can be made by interpreting the studies that the anatomy is important and more important than the level of symptoms. and would suggest that it's hard to treat that patient medically unless there were such comorbidities and contraindications.
Thank you very much.
Dr. Jahangiri, I think this is one subject where all the guidelines have given a categorical class 1 recommendation for revascularization for left main. And this is based on data that is incontrovertible. All 3 trials, CAS, European Coronaries, VA study, showed an overwhelming benefit for CABG over medical therapy in left main disease that was statistically significant. The degree of treatment effect on that was so large that people have said that there will never, ever be another trial against CABG versus medical therapy for left main. It would be unethical for us to do something like that. So we're never going to get another trial like that. We don't need to prove that data again. And I will nitpick the American guidelines a little bit here on this, although they give a class 1 recommendation for left main CABG over optimal medical therapy. They give it a level of evidence B, which is interesting. This data, I think, is randomized, I think should deserve a level of evidence A.
Thank you very much for your comments. And I think, as we heard earlier, we will await the revisions of EACT's European Association on this sub-cohort. Dr. Victor Dayan, Victor, there's a specific question for you. Thank you so much, from Dr. Vikram Kumar. Thank you so much, Victor. Kindly let us know about the AHA response of your letter from the Latin American Association. Have you received the response?
Thank you very much for the question. Yes, we received the response, and as a matter of fact, it's public, because we even, I think it's posted on our website, but several of our members have already tweeted it and put it in social media. And the response is what we have expected to have a response. The leadership, ACC leadership, backs up the guideline authors, and there is no room for negotiation nor for having a step backwards in order to reanalyze the data. And as a conclusion, guidelines are the tables of Moses, so they are unchangeable.
It's very important. Thank you very much for giving our interested party your answer. One last question in the Q&A section, which applies, I suppose, to any trial. Dr. Emad Ibrahim from Germany, Bad Nauheim, he's asking, what are the methods that the surgeons may apply to reduce the influence of stent companies who are financing all the trials with the intention to upgrade PCI systematically? It's a very wide question. I think some of the answers were given by Dr. Sabik in his how to select the committee and so on. But please feel free to answer.
I think they're very different approaches between our AHA, ACC, the American guidelines and the European guidelines. From what I know, and Dr. Sabik, you can correct me. In the American approach, anybody who has a conflict of interest can be part of the committee, but cannot vote or cannot participate in the votes on the actual recommendations. And I believe that you are very rigid about that, and in trying to apply that as much as possible. But somebody who is conflicted can participate in the discussion and have a shape in where the panel makes its decision in a way. In Europe, the way we've worked with ESC is that we have representatives from ESC and EACTS who review all the conflicts of interest, and essentially any financial conflict of interest above a certain amount per year directly paid to an investigator or to a potential panelist is considered too much to be conflict free, and so we exclude them completely from the panel. The chairpersons need to be conflict free, completely conflict free, and that includes no equity ownership in any company that could be involved. Now, that involves the financial conflict of interest of the people who are involved in the guidelines. That doesn't tell us how the trials are run, and the people who are involved in the trials, of course, that the guideline committees have to work with.
Thank you very much, Patrick. These were really helpful comments. If I may, just before we close this session, I'd like to read out some of the comments, which essentially is an extension of what you've said, but they're very interesting. Dr. David Varghese saying, dear panel, should the downgrade be applicable to only PCI? Anybody would like to make a comment? Dr. Arai, you're smiling. Would you like to say something?
Yeah, actually, yeah, it can only apply to the PCI. CABG must be a class 1. And today I am very impressed with this unity of the surgeons. So we have to make our unity and then make surgeons guideline by us, intercontinental guideline. And recently in my society, I established, I organized an intelligence analysis committee in my surgical society. So because most of the surgeons are not good for reading cardiologist papers, so I selected some intelligent guides and to deliver the thoughts and the information of the up-to-date information. Because in Japan we are not native English speaker in Japanese, so we are a little bit late for the information. So let all the Japanese surgeons to know their information in Japanese. So I organize that kind of thing. So please unite together. Thank you very much.
Dr. Arai, thank you very much. That links to a comment that I'm going to read to you. Dr. Yi Jim is asking, will the various surgical societies decide to come up with their own CABG guidelines as a counter? If I may, I'll make a comment on Dr. Jim's comment. I think, as you heard, we're saying we don't want another, 35 counter arguments, but you've seen great unity across all the continents, and we leave it to people who have experience of getting us together and help to revise the guidelines or come up with a evidence-based management of coronary artery disease. Another person, essentially people are thanking you all, and somebody else is asking, Dr. Karim Bedair, I think, Dr. Bedair, I think your comment we've addressed. The unfortunate reality is there is more than science that influences guideline writing. Yes. How can the surgical societies ensure that the surgeons of the guideline committees represent the overall surgical voice? I think, Dr. Bedair, thank you for your question, but the interest of time, Dr. Myers and Dr. Sabik have answered that, and we really hope that this forum has given us some hope that we can get together as an intercontinental society, put our conflicts of interest aside, but not our passions for what we do, and come up with an evidence-based, not too complex, something practical for the clinicians and the patients. If I may, before I close this session, I'd like to, of course, thank our panelists for their time and for their very open discussions. Thank you all the listeners and future listeners, and of course, thank CTSNet organizers for having organized this forum. Thank you very much for being with us, and have a good day, whatever time of the day you're at.
Thank you.
Thank you.
Thank you for attending this CTSNet webinar. As a reminder, a recording of today's webinar will be available next Tuesday on ctsnet.org and CTSNet's YouTube channel. If you enjoyed this webinar, CTSNet has another upcoming webinar on March 25th. It is titled Lifetime Management of Aortic Valve Disease, Key Considerations for Optimal Valve Selection, presented by Edward Life Sciences in collaboration with CTSNet. Please go to ctsnet.org/events to learn more and register. Thank you all for attending this webinar.